We're going to discuss placement of small diameter implants on a flat mandibular ridge to support a removable denture. Now in this particular case, you can see how the ridge is very flat, and you'll notice on the radiograph that this is very dense bone, D1 bone, with not a lot of trabecular bone or medullary bone. Now what radiographs should one take before implant placement? The standard of care is either a pantograph and a lateral ceph or a cone beam. Now I find periapical radiographs to also be very helpful with digital measuring apps. You can see here's where the implants will be placed. Now back here is pretty much solid cancellous bone with very little medullary or trabecular bone. We've got a little more in here, but we'd like to place the implants as far into the bone as possible. So local anesthesia first with Sitness Plain, followed by lidocaine 2%, 1 to 100,000 epinephrine. So this is more the bone we're working with right here. Lots of cancellous bone, very little medullary bone. You'll remember the densest bone, the hardest bone is in the anterior mandible, D1. The second hardest bone is in the posterior mandible, D2. The fourth hardest is in the anterior maxilla, D3, and the softest bone is in the posterior maxilla, D4. And as the patient ages, you have bone disintegration in the mandible, and as we've all seen, the mandible comes forward and gets closer to the nose. The signs of posterior or vertical dimension loss are downturned corners of the mouth, thin lips, horizontal lines in the face. A lot of times patients will have angular cheilitis or chafing redness at the corners of the mouth, and it just looks like this part of the face has collapsed. So one of the things we're going to do in the small diameter implant cases is reestablish the proper vertical dimension, and we'll talk about that on another video. Okay, so I'm palpating the mandible and just determining the extent of the bone of the alveolar process. This is chlorhexidine, and I'm going to start with a pilot drill at 1200 RPMs. Something you want to be aware of is the safety zone. You'd like to be 7 millimeters anterior to the mental nerve if possible, so you avoid the mental nerve loop. So identify the mandibular mental foramen, and you can do that a couple of ways. Sometimes you can just palpate it. Another way is to make a vacuform tray and place some gutta percha cones on the tray with Scotch tape, something like that. Place it on the mandible and take a radiograph, a periapical radiograph. Then you can identify the gutta percha cone in relation to the mental nerve and determine exactly where the mental foramen and the mental nerve are. So this is the technique, pilot drill, and with the pilot drill, if it's a normal mandible and you've got plenty of medullary bone, you just pierce the cortical plate. Then with the finger screw, you screw the implant as far as you can into the bone. Then you come back with a winged wrench or a ratchet wrench and complete the process. So in a perfect world, the apex of the small diameter implant is anchored by cancellous bone. Then you have, of course, the medullary bone in the body of the implant. This doesn't happen all that often, and they're very stable as long as you've got at least 10 millimeters in this cortical bone in the coronal part and the medullary bone in the body part, and you have multiple implants. This is high water, up and down movement, and since I'm trying to engage the cortical plate apically, I'm going a little bit deeper. This just is a radiograph to tell me where I am. So this is a 2.0 millimeter implant. Now normally on the mandible you use 2.0. On the maxilla, with this particular brand, you use 2.5. Now with 3M, we used a 1.8 or a 2.1. And then in the maxilla, we used a 2.5 or a 2.9 millimeter diameter implant. You want the implants to be as long as possible. The longest is 18 millimeters. So they go anywhere from 10 to 18 millimeters in length, and from 1.8 or 2.0 to 2.5 or 2.9 millimeters wide. So the wider ones are for the maxilla, the thinner ones are for the mandible. Just because this bone is so much denser, it's harder to screw the implant in. Now there is an exception to that rule if we're doing a surgical procedure and extracting the teeth, and I'll show you that on a forthcoming video. You can use a larger implant in the mandible. So here's the finger driver. Now you should not be able to screw the implant all the way in with the finger driver. If you do, the implant is not going to integrate and you should remove it and move to a different location. So I'm not worried about 35 Newton centimeters of torque. What I am concerned with though, I don't want to be able to screw the implant any further into the bone with the little finger wrench or finger driver. It should take the winged wrench or the ratchet wrench to screw it in any further once you've put it to place. Okay, so I'm trying to engage the cortical bone at the apical part of the mandible. Is the reason I'm drilling further. Now I'm not worried about the pilot drill extending deeply into the bone in the anterior region because I know where my middle nerves are, middle foramen, and there's not any innervation in this part of the mandible. There are no nerves I'm worried about. Now in this case, I'm using the ratchet wrench just because vertical dimension wasn't a problem. I didn't have enough room to use the winged wrench. Let's talk about middle nerve identification. This is a very easy way to do that because you know you're safe in the very anterior part of the mandible. So once these two implants have been placed, take a periapical radiograph of here and another one here. The left side, you want this implant included in the periapical radiograph and get as far back as you can so you also include the middle nerve. On this one, again, you want that small laminar implant included in the radiograph, and then you want the radiograph to extend far enough distally to capture the middle nerve so you can see it on the radiograph. Then take your digital measuring application and measure from here to the middle foramen on the radiograph, on that periapical radiograph, and just be sure you're 5 to 7 millimeters mesial to the middle nerve. Now, as you get closer to the middle nerve, I try to move the implant just a little bit lingually, not into the non-keratinized gingiva, but all the action is out here on the facial, unless the ridge is resorbed enough that the middle foramen is pretty much on the top of the ridge. So bottom line, measure digitally from this implant, place these two implants, then measure from this implant to the middle nerve and stay 5 to 7 millimeters mesial to the middle nerve. So I'm well anterior to the middle nerve. Now something you've got to worry about with the middle nerve in a patient with a flat ridge. It's sort of like a flounder. If you know what that is, the flounder has both eyes on the same side and it just lays flat on the ocean floor. Well, the same thing happens to the middle nerve if you've lost a lot of bone that middle nerve will come up to the top of the ridge. The mental foramen could be on top of the ridge, and so if you went back too far distally, you could be drilling right into the mental foramen. So it's very important that you identify the mental foramen before you drill your pilot hole distally. You want to be sure you're at least 7 millimeters mesial to the middle nerve. And be especially careful in these flat ridges, because it could have migrated up here to the top of the ridge, and the middle nerve is actually on top of the mandibular bone. Now I'm going to constantly check my angulation with a large mirror to be sure that they're generally parallel. Now, one of the great things about small diameter implants versus root form implants, and I place a lot of both of them, is you can have a 30-degree divergence with small diameter implants from the other implants. They can be 30 degrees off, and that's fine, and it actually enhances retention of the removable denture or partial. So you've got a little more latitude with placement. Something else to think about, we've got to be conscious of attached gingiva around implants, just like we are conscious of attached gingiva or keratinized gingiva around natural teeth. So if there's not enough attached gingiva, you should do either a free gingival periodontal graft from the roof of the mouth, or now we use perioderm. And I have a video on perioderm placement in relation to small diameter implants and minimum attached gingiva. So if you can get 4 on the mandible, and that's ideal. You can see these are nice and parallel. If you can get 4 implants in the mandible and ideally 6 in the maxilla, that's wonderful. Now, sometimes, especially in the maxilla, you have a hard time finding good bone. And I've had very successful cases where you only had 2 in the maxilla. But ideally, you'd like 6 in the anterior maxilla and 4 in the anterior mandible. So the 2 ways to check and see if your implants are solid: 1, you can't turn the implant anymore with the finger driver or the finger wrench. Number 2, when you tap the implants with the end of a mirror handle, the sound should be ting, 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 and not thud, thud. Ting, ting, ting. That's my favorite sound. Ting, ting, ting. Now I'm checking them with the finger driver, and I can't screw them in anymore. So these implants have a very, very high success rate. You can see where each of these was 15 millimeters. And so we've got lots of stability. Now, how do you know when to stop screwing the implant in? Well, I want the shoulder of the implant to be slightly subgingival. The shoulder of the implant, right here, to be slightly subgingival. You would like all the threads to be into the bone, if possible. Sometimes that doesn't happen, and that's okay. That's okay, because you can't keep screwing them in, to try to get all these threads in the bone. At that point, you wouldn't have any of the implant sticking up for the housings. So here we have healing 2 weeks post-op.
We're so happy you joined us this week on the Dental Minute. Make sure you subscribe right now, because next week we are talking about soft tissue grafting, and you will not want to miss this episode. We'll see you next week.